Hello, my name is Stephanie Villalobos, and I am a physician assistant that works on 9 ICU in the cardiothoracic and transplant ICU. And today I will be giving a lecture on intracranial hemorrhage and the different types of intracranial hemorrhages that exist. This is meant to be a broad overview in regards to each type of intracranial hemorrhage and will hopefully help you in regards to knowing kind of where each intracranial hemorrhage is located, how these patients present, what patient population it's most common in, how to diagnose these patients in regards to what imaging to choose whenever you suspect that a patient might have an intracranial hemorrhage, what is the treatment and management. And I can guarantee you're going to see these patients, and no matter what ICU you rotate through, obviously you'll probably have more experience with these patients in the neurovascular ICU. My goal is also in the future to hopefully make a specific PowerPoint presentation and lecture on each intracranial hemorrhage separately, but this is just meant to be more broad. So intracranial hemorrhages, let's talk about the 4 different types. So each type of brain hemorrhage has a unique cause, as you can see on the right side. It has different clinical findings. It also has different findings on a CT head, different prognosis and outcomes. And as you can see on the right side on this picture, it's located differently in the brain, and that's kind of how you can tell where and what each intracranial hemorrhage is. So let's talk about each one. So we have our epidural hematoma, we have our subdural hematoma, our intracerebral hemorrhage, and then our subarachnoid hemorrhage. So let's talk about epidural hematoma. So just kind of the basics for an epidural hematoma. 90% of epidural hematomas are arterial bleeds. So that's going to be the most common cause of an epidural hematoma. Usually textbook-wise, they would teach you in PA or in NP school that the most common location is usually due to a laceration of the middle meningeal artery. So most of these are arterial bleeds. Although some of these can be venous bleeds, 10% are venous in origin and are usually due to fractures that cause laceration of venous sinuses, but most of these are going to be arterial. And usually these epidural hematomas respond well to prompt drainage, and they have a very good favorable prognosis. And how these patients present is that they have a lucid interval after the trauma, followed by loss of consciousness as the epidural hematoma rapidly expands. Although sometimes lucid interval usually occurs in about 20% of cases, so it doesn't occur in every single patient that presents with an epidural hematoma. So what is the first thing you're going to order for these patients that you're concerned that they might have an intracranial hemorrhage? Is that you're going to get a CT head. So usually it's going to be a non-contrast CT head, stat non-contrast. And as you can see, what you're going to see is your classic lens-shaped hematoma. So your lenticular lens-shaped hematoma. And it's usually associated with an underlying skull fracture because most of these are traumatic. So about 85% of these have a skull fracture, which you can see on the right on the CT head also. So what I've noticed is a lot of students, including some residents, do have difficulty trying to differentiate an epidural hematoma and a subdural hematoma. So epidural hematomas do not cross suture lines. And the reason why they do not cross suture lines, whereas subdural hematomas can, is that epidural hematomas are usually located above the dura mater. And if you think about it, the dura is tacked on strongly, very tightly to the skull at these lines. So if we understand that epidural hematomas occur above this dura, then you're going to think about these not crossing the suture line versus, like I said, subdural hematomas do cross suture lines. But an epidural hematoma can cross the midline or cross between supratentorial and infratentorial regions where subdural hematomas don't. Epidural hematomas usually don't extend into the interhemispheric fissure, whereas subdural hematomas can. So here is an imaging, just a picture in regards to the anatomy and pathophysiology that you're seeing in these head bleeds. So as you can see, an epidural hematoma is usually going to be an arterial bleed. Like we said, it's associated with a skull fracture, the middle meningeal artery, and it's usually going to be very rapidly expanding with arterial bleed because usually arterial bleeds are very brisk in bleeding. And as we said, this occurs above the dura mater versus your subdural hematoma. It slowly expands with venous blood And as you can see, the dura is completely attached to the skull, and this subdural hematomas occur under the dura mater. So what is the management for these patients? So usually treatment for this is going to be surgical drainage. As you can see in this image here, you can see a pretty large epidural hematoma on your left side, and you have your subdural hematoma on the right side. So once again, lens-shaped versus on your right side, your subdural hematoma is going to be your crescent-shaped. So indications for surgical drainage, if it's pretty large, so more than 30 milliliters of volume, as you can see in this image, that one's pretty large, and it's actually even causing some midline shift. It's causing it so bad that I can't even see the ventricles. So midline shift, thickness, if the patient also has impaired consciousness or any type of asymmetric pupils. I mean, asymmetric pupils already tells you that there's concerning for impending cerebral herniation. New focal neurological signs, like say they're more drowsy, more sleepier, they can't move like the right side or the left side. And then also if you're usually getting CT heads for these patients, you're trying to observe to see if the bleed is getting bigger. And if it is, then that's concerning that maybe you need to take them for some type of surgical intervention. And if they have posterior fossa syndrome. So what is posterior fossa? So usually with posterior fossa, if you think about it, right, the posterior fossa is located infratentorial, so that's on the bottom of the brain, and it's close to the cerebellum and the brainstem. So a bleed there that starts expanding, especially an arterial bleed, an epidural hematoma that's brisk and it's bleeding quickly and getting large quicker, you have a very limited space in the posterior fossa because you're at risk for basically cerebral herniation, okay? Which we're going to discuss the Monroe-Kelly doctrine in a bit and why it's so important to make sure you decompress the brain in these situations, because you can basically go into cardiac arrest. Because if you think about your cerebellum, and more specifically your brainstem, you have a lot of cranial nerves that run through there that are responsible for breathing, right? We think about the vagus nerve, responsible for your heart rate, your pupils constricting, extraocular movements, etc. So it's really important to make sure that you address these hematomas, specifically in the posterior fossa, because you're at higher risk of uncal herniation or just cerebral herniation than a hematoma that might be a little bit higher. So I know I discussed a little bit about the Monroe-Kelly doctrine, as you can see here. So the Monroe-Kelly doctrine, in a normal patient like you and me, a normal person, we have normal venous volume, we have arterial volume, we have brain, cerebral spinal fluid. So this is all that lives under the skull, intracranial, in the brain, okay? Say you get some type of space-occupying lesion like you see there in that middle image, whether it's a tumor, an abscess, or an infection, right? Whether it's a cardiac arrest, for example, and you have some neurons that are just dying and causing inflammation. Whether it's a bleed or a tumor, your brain can compensate for a little bit of time, right? So your intracranial pressure is normal. But if that lesion starts getting larger, as you can see in that last image, it starts compressing everything else, okay? And that's where your cerebral autoregulation becomes decompensated and you start having high intracranial pressures. So as you can see, any increase in any one of the skull components, brain, tissue, blood, cerebral spinal fluid, basically necessitates a change in the volume of another. So increased intracranial pressure decreases cerebral perfusion, can cause ischemia, cell death, and further cerebral edema. And the worst is going to be your cerebral edema because, like we said, you start herniating. You can herniate in different ways, but you can cause herniation and start compressing your brainstem and can go into cardiac arrest. So usually treatment for this, for your epidural hematomas, if the bleeding's worse, is going to be a craniotomy. And you can also do a burr hole evacuation. So usually with the burr hole, you do this small hole that's drilled in the skull, and suction is issued to kind of remove that hematoma. So let's go into our next one, which is going to be our subdural hematoma, and just basics, kind of like the broad overview. So usually this is going to be damage to the bridging veins. So this is going to be a venous blood versus your epidural hematoma, which is going to be an arterial bleed. So this is going to be due to bridging veins that lie between the cerebral veins and the dural venous sinuses. And since subdural hematoma usually results from a bleeding vein, the onset is generally more gradual than your epidural hematoma, like we discussed already. And usually acuity is based on delayed presentation. So an acute subdural hematoma presents 0 to 3 days after trauma. A subacute subdural hematoma presents 3 to 14 days after trauma. And a chronic subdural hematoma presents 15 plus days after trauma. And sometimes you can get acute on chronic with these patients. So acute on chronic, you think about is going to be your elderly patient that lives in a nursing home, has dementia, falls, had a head bleed, right? But you can't really tell whether the patient's altered. And so they have this acute that develops into a chronic subdural hematoma, and then they fall and they hit their head again, so that you have this acute on chronic subdural hematoma. And some of the causes, which I kind of went into it already, more commonly found in your older patient population. And the reason why it's more commonly found in your older patient population is that usually with your older patient population is that as we age, our brain atrophies, which can sometimes lead to like stretching of those bridging veins, and the stretching can increase the susceptibility of basically having a subdural hematoma in your older patient population, because these bridging veins are a little bit more fragile, more friable, and they're more prone to rupturing, basically. And so that's why in elderly patients, any type of multiple falls and ultramental status, for example, should maybe think about a subdural hematoma or a bleed, or obviously stroke, but just think about that in your differential diagnosis. Also, most of these patients, right, or older patient populations are on some type of anticoagulation, whether it's for their history of AFib or, for example, for a history of a stroke. So they're at risk for developing a subdural hematoma following milder trauma. Versus your younger patients, right? Usually subdural hematoma is often a marker of a severe traumatic brain injury. And usually, what is a traumatic brain injury? Just like it sounds, what happens like from a pathophysiological standpoint is that you get this diffuse axonal injury. And how we think about it is our axons, right, in our neurons. You get this shearing and tearing of the brain. And these long connecting fibers, your axons, get basically sheared and teared apart. And this happens whenever the brain is injured. So as it shifts and rotates inside the bony skull with like a car accident or any type of trauma, you can cause basically damage to these axons, and like I said, and then you're at risk for subdural hematomas. And so other causes of this can be post-procedurally, so due to a lumbar puncture, and then also overdrainage of a ventricular or lumbar drain. So how does that happen whenever you overdrain? So say you put in a shunt for a patient that has cerebral palsy, for example, or they have some type of intracranial tumor that is causing obstructive hydrocephalus. Usually these shunts or even lumbar punctures, right, it basically drains excess cerebral spinal fluid from the brain, which can lower the intracranial pressure. But if too much cerebral spinal fluid is drained at once or just subsequently, the ventricles in the brain can decrease in size, and this can cause the brain to pull away from the skull, which can cause stretching and tearing of those tiny veins that connect the brain to the surface, to the dura mater, and this can cause also your subdural hematomas. So how is this patient going to present with the subdural hematoma? So the presentation can vary depending on the acuity, right? Like I said, if they're associated with traumatic brain injury, usually these patients are going to come in and they're just completely altered where you need to intubate them. And it also depends on the location of the hematoma. The thing about subdural hematomas is that sometimes they can exert diffuse pressure on the brain without causing focal neurological findings. So that means that sometimes they can present with generalized, non-specific presentations versus a focal presentation, right? So focal, we think about a specific area like hemiparesis, where they can't move like the left side, aphasia, where they have trouble understanding or speaking. So that's going to be your focal neurological findings versus a generalized finding, which is not really specific, like headache, okay? Coming with a headache, you have a huge differential diagnosis for that. Nausea and vomiting, confusion, there's a huge differential diagnosis versus like a focal neurological finding. You can basically pinpoint that the reason for that is something intracranially that's happening in the brain. And then you can have posterior fossa subdural hematomas. And usually these can cause vomiting, cranial nerve deficits, cerebellar symptoms, and headaches. Usually if it's posterior fossa and it's located there. And if we think about it, right, posterior fossa, that's going to be infratentorial. That's going to be at the bottom of the brain. And any type of bleed here, it's close to the cerebellum, it's close to the brainstem, you're at risk for herniation because you're at higher risk for that bleeding getting bigger and compressing the brainstem, and basically you can go into cardiac arrest. So imaging for this, like we discussed starting, I think I've kind of harped on that already multiple times, is just that subdural hematomas are crescent-shaped on imaging, as you can see here. They can cross suture lines, okay, versus an epidural hematoma cannot. And usually sometimes there's been some discussion that you can see a swirl sign, and if you see a swirl sign, that's concerning that maybe there's active bleeding. Fluid fill level also can suggest the presence of a coagulopathy. We discussed most of our older patients are on anticoagulation medications. And then the good thing about CT scan is it can tell you about the chronicity. We talked about our acute subdural hematomas or chronic subdural hematomas, acute on chronic subdural hematomas. And so acute blood is usually hyperdense, as you can see here in the first image, so like very bright. And then you have your subacute subdural hematomas that become isodense on days 4 to 21. And then you have your chronic subdural hematoma, which is the last one on your right, which can present hypodense, okay? So it's a little bit more dark. And then if you have a patient, like I said, that presents with acute on chronic subdural hematoma, this is usually due to rebleeding, like we said. So what is the management of acute subdural hematoma? If the patient's anticoagulated, then obviously anticoagulation reversal. If you want to make sure that you're monitoring these patients also because they're at high risk for decompensation and deterioration and expansion of the bleed. So you want to make sure that usually these patients, you manage them conservatively. What does that mean? Is that you're checking like Q1 or Q2 hour neuro checks. You're making sure that you keep the patient awake, avoiding any type of opioids that might further make their neurological exam a little bit more difficult to examine. Interval CT heads about every 6 hours until the hematoma is stable and it's not enlarging in these patients, making sure that you also take care of any electrolyte derangements like the sodium, keep them salty. Seizure prophylaxis also. Unfortunately, acute subdural hematoma is associated with a fairly substantial risk of seizures, so that should be on your differential diagnosis. If a patient has an acute mental status exam change, is the bleed getting bigger, right? Or am I missing seizures? So sometimes we do put these patients on seizure prophylaxis for up to 1 week. And in any patient that has any type of neurological exam, like I said, either order a CT head if that's negative, or if the bleed is unchanged, then get an EEG, an electroencephalogram, to see if there are any seizures. Because sometimes these patients present with non-clinical epileptiform seizures, so seizures that you can't see on exam, but you can see on an EEG. So treatment for this is usually going to be consulting your neurosurgical colleagues if they're not already on board. Usually they are whenever you get a CT head and you have findings that are concerning for a head bleed. But if it's something acute, right, and it's quickly enlarging and you're concerned that maybe the patient needs surgical intervention, then obviously get them on board stat. So consult your neurosurgery colleagues. They are usually required to remove the hematoma. They'll do it via craniotomy. Some of the indications for surgical drainage are going to be if it's thick, the subdural hematoma, so more than 1 centimeter in thickness. If there are any signs of midline shifts, more than 5 millimeters. If they have any significant neurological exam changes, like if they have a low GCS where they're completely obtunded, they're not protecting their airway, and you're having to intubate them, and you've ruled out seizures, right? If they have any signs of asymmetric or fixed and dilated pupils, I mean, that's already signs that they have cerebral herniation, if not impending cerebral herniation. And if you have a way to measure intracranial pressure and their measurements are consistently greater than 20 millimeters of mercury, then there's our signs for acute neurosurgical intervention. It'll be usually done via craniotomy. So let's go into chronic subdural hematoma. Just one quick slide on this, just because we have an older patient population, and unfortunately, like I said, most of these patients are presenting with acute on chronic or chronic subdural hematomas. So more likely in your 50-year-olds patients, if they have a history of alcoholism, anticoagulation, or like I said, over drainage of a VP shunt. Symptoms of this usually is going to be enlargement of a previous asymptomatic hematoma that can result from either rebleeding or some type of osmotic mediated swelling of the fluid. That's why sodium is really important in these patients, making sure that when they present, you keep them eunatremic to maybe even hypernatremic, so targeting a sodium greater than 140 in these patients. Sometimes they present with ultramental status. It's kind of hard because most of these patients have like a history of Alzheimer's or dementia. You don't know if maybe it's just their baseline, or sometimes you don't even know their baseline because they've been living in a nursing home. And sometimes the nursing staff, it's not that helpful, but just keep that on your differential diagnosis. And management is sometimes these chronic subreal hematomas can exert mass effect and cause symptoms. So in these cases, it should be drained. And you can do that with a burr hole drainage or an insertion of a JP drain. All right, so let's talk about intracerebral hemorrhage. So there are different types about intracerebral hemorrhages. I think I can do like an hour, if not multiple hour lectures on intracerebral hemorrhages because there's so much information on them. But this will be really quickly and just kind of like a broad overview. So intracerebral hemorrhages refers to a primary or secondary non-traumatic hemorrhage that occurs within the brain. So location, most of these are going to be intraparenchymal, so it's going to be bleeding within the brain itself. Causes of the intracranial hemorrhages. So you have your small vessel disease. This is going to be possibly the most common cause of intracranial hemorrhage, and it's known as your primary intracranial hemorrhage. So your hypertensive intraparenchymal hemorrhage. We think about our patients that have long-standing history of hypertension or risk factors like they're older, diabetes, have multiple comorbidities. And then you have your macrovascular etiologies. So we think our macrovascular etiologies in regards to like arteriovenous malformations, subarachnoid hemorrhages, which I'll be talking about in pretty soon also in this presentation, cerebrovenous thrombosis, cavernous malformations, dural arteriovenous fistulas, mycotic aneurysms. So mycotic aneurysms are going to be your patients with endocarditis that all of a sudden have this abrupt intracranial hemorrhage. Moyamoya disease, for example. And then other etiologies are going to be malignancies, right? Ischemic strokes, RCVS, or reversible cerebral vasoconstriction syndrome, which is kind of a newer diagnosis that we've learned about in the past couple years, if not in the past decade. Coagulopathy, sympathomimetic drug use or cocaine users also. Vasculitis, so we think about lupus, sarcoidosis, rheumatoid arthritis. If you get fancy, like our Henoch-Schönlein purpura or polyarteritis nodosa etiologies. So how are you going to diagnose these patients? Usually you start with a CT head, and then you can do also a CTA and then a CT venography. Like we said, some of these causes, if you have a high suspicion that the patient might have a cerebral venous sinus thrombosis, then a CT venogram would be good. So it's usually the front line to evaluate any type of underlying aneurysm or vascular malformation. Like I said, CT venography to evaluate for cerebral venous thrombosis. A brain MRI, usually not in the acute phase, but usually once the patient's a little bit more stable. Invasive angiography is usually the definitive study for aneurysms or any type of like arterial malformation, like a dural arteriovenous fistula or vasculitis. The good thing is that it's diagnostic and therapeutic, and if you see an aneurysm there or an arteriovenous malformation, then you can basically treat it or you can embolize it immediately. So that's why invasive angiography or digital subtraction angiography is really good for these patients. I have a picture here on the right side that shows like a DSA, uroangiography, and you can basically see a subarachnoid hemorrhage in the posterior communicating artery. So management for these patients in general is going to be supportive. Make sure that you're basically in the ICU, keeping a close eye on their blood pressure, especially if it's, for example, an active intracranial hemorrhage, like a subarachnoid hemorrhage, like I said, and this patient has not been coiled or has not been embolized. You want to make sure that you keep their blood pressure low. So usually we'll use antihypertensives like drips, like for example, nicardipine that we used, or clevedipine, which are drips, and they're pretty good because they're titratable. And then also managing any type of intracranial pressure with these patients, and that's being done with, like, obviously, like we said, maintaining eunatremia, so sodium greater than 140. So this is like the patient population that you want to give normal saline boluses or even hypertonic boluses, or your 23.4% bolus of like hypertonic fluid in these patients that can help basically lower your intracranial pressure, or mannitol, for example. And then obviously if the hematoma is getting large, call your neurosurgery colleagues for hematoma evacuation. And once again, depending on the etiology of it, it's going to be basically the treatment. And as you can see on this photo, on this right side, on this image, it's all the different types of etiologies for your intracerebral hemorrhages, as you can see here. So let's go into our last topic, which is going to be our subarachnoid hemorrhage. This is probably my favorite. I love subarachnoid hemorrhages. I feel bad for the patients, but I think just the physiology and the pathology and everything that's occurring is very interesting. So there are multiple causes of subarachnoid hemorrhages. So you have your primary causes of subarachnoid hemorrhage, and you have your secondary causes of subarachnoid hemorrhage. So your primary causes, 85% are going to be aneurysmal. So we think about, or for example, our berry aneurysms that rupture. 10% are going to be perimesencephalic, so that means bleeding around the midbrain. 5% are going to be due to other type of vascular malformations, which were kind of discussed already in the prior slides. So your arteriovenous malformations. We think about these arteries that are just fragile, more prone to getting ruptured. Dural arteriovenous fistulas, for example. Arterial dissection. Our moya disease. So usually with the moya, we get a lot of patients with Down syndrome that would come in with like acute subarachnoid hemorrhages. And if we think kind of the physiology and pathology of moya is that usually these patients have narrowing and blocking of the ICA's intracranial, the internal carotid arteries and their branches. And so basically, since they have blockage and kind of like stenosis of these arteries, what happens is that they create these like collateral vessels to try to compensate for these blocked arteries. So they're more prone for these arteries rupturing. They're more fragile, so they're at higher risk for like your subarachnoid hemorrhages. Some of the secondary causes of subarachnoid hemorrhages, sometimes it can be traumatic. So it'll be a patient that presents with like a traumatic brain injury and other like bone injuries, for example, so MVCs. RCVS, or reversible cerebral vasoconstriction syndrome, also, just like it sounds, it's vessels that constrict in the brain. PRES, posterior reversible encephalopathy syndrome, that should be on your differential diagnosis for any patient that comes in with seizures and they have a history of hypertension or end-stage renal disease or consistently hypertensive. Think about PRES. Cerebral venous sinus thrombosis, like I said, so just like it sounds, you basically get a thrombosis and a clot in your cerebrovenous sinus. Very common in women, specifically women of bear aging, like women that are prone to pregnancy, like so in your 30s, or women that are on history of, for example, birth control. Cerebral amyloid angiography, pituitary apoplexy, CNS vasculitis, like we discussed already, tumors, coagulopathy, sympathomimetic use, so cocaine, very commonly in mycotic aneurysms, so it's going to be your patients with endocarditis. How do these patients present? So classically, textbook, they tell you about this thunderclap headache that these patients present. And interestingly, a single thunderclap headache is usually more worrisome than a patient that tells you that they have a history of like multiple similar headaches. And so usually it's going to be a patient that presents and they tell you, you know what, doc, it's been like the most severe headache I've ever had in my life. They also present with meningismus, so some neck pain, also neck rigidity. Elevated intracranial pressure signs, for example, emesis, reduced consciousness. Sometimes they're completely out if they have a pretty high degree subarachnoid hemorrhage. Focal neurological exam changes, whether it's problems with their speech, like aphasia, like I said, they can't move one side, like hemiparesis, seizures also. And then if it's a very severe subarachnoid hemorrhage, like we said, sudden death. And this is a picture of like a ruptured aneurysm here and your middle cerebral artery, which is not a good area that you want to have a subarachnoid hemorrhage. So subarachnoid hemorrhage grading scales, kind of wanted to discuss a little bit about that. And so subarachnoid hemorrhage grading scale. So the subarachnoid hemorrhage severity is expressed using various scores. Usually the Hunt and Hess score is the one that we use more widely. The weakness for the score, as you can tell, so it scores 1, 2, 3, 4, 5, and it's basically how the patient initially presents. So if they're asymptomatic and they have a mild headache and some nuchal rigidity, you get a CT head and you're like, oh, it's a subarachnoid hemorrhage, then you're going to give them a grade 1, right? But if you go up to grade 5, it's a patient that was basically how it's usually described is that they were out in the field, they fell and just collapse, and they're intubated when they come in, and they're not arousable, and they're posturing, and that's like a Hunt test score of 5, right? The thing about this and why there's a lot of questioning about it is that sometimes these patients can be very obtunded because they have hydrocephalus. So say you put a ventricular drain in to kind of try to remove that pressure, then these patients will wake up, and I've seen it. So they'll present with like a GCS of 3 or 4, and then they go to a GCS of 1. So that's why sometimes I think it's important I think it's important what the neurological status is after the initial resuscitation and hydrocephalus management than the initial presentation of the patient. And then you also have your modified Fisher scale, as you can see here on the right, CT heads. And it's basically how big is intraventricular hemorrhage, or how big is the bleed. So grade 1 is like no or minimal subarachnoid hemorrhage bleeding, no intraventricular hemorrhage, up to like grade 4, which is basically diffuse or focal thick subarachnoid blood with intraventricular hemorrhage, which you can see bleeding within the ventricles here, in D here. So depending on what Hunt test score they have or modified Fisher score they have can kind of tell you prognostically whether this patient would have a good prognosis or not, and whether these patients are at risk for vasospasm, which I'll discuss upcoming. So diagnosis, usually it's going to be a non-contrast CT. CTA is very sensitive and specific. It's about 95% for aneurysm detection. And usually for these patients also lumbar punctures. So say you get a CT head for a patient and you're very sure that the patient has a subarachnoid hemorrhage, but you want to make sure that you're 100% sure. The next thing you can do is lumbar puncture. So like I said, used to evaluate for subarachnoid hemorrhage in patients with a negative CT head with high suspicion for subarachnoid hemorrhage. And usually what you'll see in these patients is going to be xanthochromia. MRI and MRA also, and then your invasive angiography, like we said, your digital subtraction angiography, which is going to be both diagnostic and therapeutic. So say you have a patient that presents with acute neurological deterioration, and they have subarachnoid hemorrhage, which should be on your differential diagnosis. So concern that maybe they might be rebleeding and the subarachnoid hemorrhage is getting bigger. So in these patients, you want to make sure you get a stat CT head. Rebleeding concern, especially if the patient has a higher grade of a subarachnoid hemorrhage on your Hunt test or your modified Fisher score. If they have a large aneurysm, if they have a history of hypertension, antiplatelet therapy, or some other type of coagulopathy. Seizures, intracranial pressure elevation, especially most of these patients have EVDs, external ventricular drains, which is a drain that goes into the brain just like it sounds, and it kind of just measures your intracranial pressure. So if their intracranial pressure starts getting higher than 20 millimeters of mercury, then you're concerning, and it's refractory to like hypertonic boluses, then you're concerned that maybe they might be having worsening bleeding, for example. Vasospasm is going to be a big one, and delayed cerebral ischemia. So vasospasm occurs in about 3 to 14 days after subarachnoid hemorrhage. Specifically, once again, the higher grade the patient has, modified Fisher score and your Hunt test score, the higher risk they're at having a subarachnoid hemorrhage. And what is vasospasm? What is that? So basically how it sounds, it's basically your cerebral artery, the vessel that had the subarachnoid hemorrhage that burst and started bleeding everywhere. The bleeding, you have these RBCs, red blood cells, that breaks down and starts creating all these basically chemicals that irritate the vessels, and it causes the vessel to kind of spasm, so kind of clamp down. And whenever it clamps down, and specifically if it clamps down for a really long time, the patient can present with a stroke-like symptom. And so sometimes these patients will present with like all of a sudden aphasia, or they can't move their right upper extremity, or their right lower extremity, they're weaker. So they're at risk for vasospasm. And usually It occurs 3 to 14 days after subarachnoid hemorrhage, and peak risk is around days 7 to 10. So usually these patients, when they present, you want to see what day they presented. So say they presented on Tuesday, that's going to be your day 1. And then you kind of count day 2, subarachnoid hemorrhage, day 3, subarachnoid day 4. That way you know that around day 7 to 10, they're at risk for like vasospasm, especially, like I said, your higher grade subarachnoid hemorrhages. And usually their vasospasm risk resolves by day 21. So sometimes these patients are going to stay in the ICU for a total of like 21 days. So they can stay in the ICU for a pretty long time. And the risk for vasospasm is that these patients can develop delayed cerebral ischemia. And only half of patients with vasospasm have tissue ischemia with neurological deterioration. And prevention of delayed cerebral ischemia, so how do we do that? So we want to prevent vasospasm to prevent further ischemia to the brain. So we do this by giving them nimodipine, which is a calcium channel blocker that specifically kind of targets the cerebral arteries. You want to maintain euvolemia in these patients, so just making sure that they're not specifically dry. Lasix, when I was in the neuro ICU, was kind of the enemy. We would not use Lasix. We would keep these patients wet. Although, like, new literature is showing that we're trying to kind of get away from euvolemia just because it's been shown to cause pulmonary edema, and some of these patients develop neurogenic pulmonary edema. And then also making sure that you keep their magnesium levels normal, because the magnesium is kind of like a normal calcium channel blocker that works in the body. So what is going to be the management for these patients just for overall subarachnoid hemorrhages? So in general, it's going to be supportive, right? So airway management, specifically in your higher Hunt test scores, your higher modified Fisher scores, your Hunt test score of 5, modified Fisher of 4, where these patients come in and they're obtunded, they're intubated, so airway management, or these patients that would bleed, for example, analgesia. A lot of these patients get really severe headaches that do not respond to opioids. Opioids do not work just because it's a different mechanism and pathophysiology of the reason why they're having these headaches. And not only that, we try to minimize opioids because, one, they don't work, and two is their neurological exam is so precious to us that any change in neurological exam will basically make us have a differential diagnosis for these patients, right? Are they seizing? Is their bleed getting bigger, for example, etc. And so if you give them an opioid like oxycodone or fentanyl, you don't know if it's because of oversedation of the medication or is there something intracranially that's happening. So in these patients, pain medications like gabapentin, Tylenol is really good, magnesium is really good. Also, other management is that these patients can get cardiopulmonary complications, as you can see in this picture here. It's usually due to this basically dysfunction of the autonomic center, where you have more sympathetic drive than parasympathetic drive. So if you have more sympathetic drive, right, it's going to specifically go to the nerve fibers that are located within the apices of the heart. And so it's going to target those, and these patients can get something called Takotsubo's cardiomyopathy, also known as your broken heart syndrome, as you can see here in the picture. And the reason why it's named Takotsubo's is that it looks like what in Japan they use to trap octopus. So basically the ventricles, they get super dilated. So they have this dilation of the ventricles that causes this Takotsubo's kind of picture like when you do a point of care ultrasound. Not only that, they can get microvascular dysfunction, which can cause endothelial and capillary dysfunction within the lungs. So these patients are prone to getting neurogenic pulmonary edema from that. And not only that, we're keeping these patients wet, like I said, because we're trying to give them fluids to try to keep those cerebral vessels open and patent to prevent vasoconstriction. So these patients are at risk for multiple things. And so management, again, is going to be also controlling fevers, anything that can cause metabolic demand within the brain. So fevers, these patients, especially, like I said, your higher Hunt test grade patients, like your Hunt test 4 and 5, most of these patients are intubated. So they're at risk for like infections like ventilator-associated pneumonias, hospital-acquired pneumonias, sepsis, right, bloodstream infections, bacteremias. Some of these patients have drains in their heads, so they're at risk for like cerebritis, meningitis, encephalitis. For example, And then not only that, sometimes these patients can have also other causes of fevers. So we think about our first cause of fever and then other causes of fever, like central fevers. So unfortunately, since they have this brain bleed, they get this, and we think about what controls fever within the brain, which is the thalamus, right? And so if they have a pretty big brain bleed, they can't really regulate temperature. So that should be on your differential diagnosis. If you've ruled out infection, then maybe they have a central fever that's coming from a brain, and it's just dysregulation from the brain. And so making sure that you treat the fever, because the longer they are fevering, they are basically increasing metabolic demand and increasing how much the brain is working, and they are at risk for further worsening brain ischemia. And like I said, also avoiding hyponatremia for these patients, making sure you keep them salty, which we can talk about the physiology and pathology in other lectures in regards to why sodium is so important within the brain. Surgical coiling or clipping is usually going to be the treatment for these patients, as you can see in these pictures here. Clipping of the cerebral aneurysm, so they go around the neck of the aneurysm and they clip it, or they go in there and they kind of just coil it, and this will prevent it from rupturing or further bleeding. And that's it. Thank you for your time. I feel like neurophobia is something that a lot of students and even providers in general kind of struggle with. So if you overcome that, you will be able to deal with any neurological problem that occurs whenever you have a patient that has, for example, seizure or an acute bleed. If you have any questions, these are my emails, and I have a YouTube channel also, so hopefully it's helpful. Thank you. So I want to talk about the University Health Critical Care APP Fellowship that University Health has. So this is a fellowship for NPs and PAs that are interested in critical care medicine. And it's a 12-month postgraduate training program in critical care medicine, and you rotate through multiple ICUs. It's 12 months, so you'll be rotating through the neurovascular ICU, the cardiothoracic and transplant ICU. You'll rotate through a medical ICU, a surgical ICU, etc. And then you'll also be doing other electives, for example, a month in with, or several weeks with anesthesia with intubation. So the purpose of this fellowship is to make you a well-rounded APP to be able to practice in whatever specialty in critical care you want to practice in. I highly recommend it. I completed one at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. It was definitely very difficult, but I think it made me a very well-rounded PA. And because of it, I've been able to do a lot of procedures, and I feel comfortable with like intubations, bronchoscopies, paracentesis, central lines, arterial lines, etc., which is something that you don't get a lot of practice in, speaking from a PA perspective, in PA school, and something that I'm very thankful for completing the APP fellowship. And then also the fact that I rotate through multiple ICUs, I was able to learn from every ICU, neuro, for example, ICU, medical ICU, cardiothoracic, because being well-rounded is going to be good, because as a APP in whatever critical care unit you go into, you are guaranteed you're going to run into, for example, if you end up doing cardiothoracic transplant ICU, you're definitely going to have a head bleed, for example, or stroke. And so the fact that you're well-rounded and you've done multiple ICUs and you kind of obtain that knowledge, and it's once again repetition, and experience, it's going to make you very good. So highly recommend it.